Hey everybody, hope all is going well. My name is Eric Norman, and I'm a physical therapist here with Mettle. And on today's podcast, we'll be joined shortly by none other than Christian Jorns, who's also a physical therapist and has been on other podcasts. Today we're going to talk about the shoulder and ideas and treatments and philosophies around shoulder impingement, or some people might call it subacromial pain syndrome, goes by many different names. So we're going to discuss things around that, and hopefully, like always, you can take something good away from this if you are having shoulder pain, or if you know someone who's having shoulder pain, hopefully it can help them out too. So, all right, everyone, thanks for listening, and we'll talk to you later. Hey, Christian, what's going on, man?
Hey Eric, things are going pretty good so far. Not working right now, took the day off. It's been a good day.
Ooh, nice. There you go. What have you been doing? Taking the day off, what have you been up to?
Doing a lot of podcast prep and other things
nice.
for our business.
Oh, there you go.
What are you doing?
Not a whole lot. Yeah, I worked today, but it was my half day. And so I got done at like 2 and then came home, and I've just been doing just homeowner stuff, just like nothing but housework since like Friday. Yeah, since Friday I sent you a picture of that shed I put up. And so I put up a shed over the weekend outside. It's not a big shed or anything, but man, there's like a million screws in that thing that just takes forever. So yeah, I've been doing that a lot, and then I bought some stuff for the backyard, so I've been trying to put that together and just trying to make the house a little more presentable. So that's what I've been up to.
Well, I will say your shed looks great, but the grass around it, it needs some work.
That is a bad spot. I know, that is a bad spot. That's a highly trafficked spot, and it's all sand, so it's tough to get going. But I'll send you a picture of my backyard. That's been my project, is the backyard grass, and that's looking pretty nice.
That's your pride and joy.
I guess I have to, I have to shift focus to the north side of the house now that you're pointing it out to me. But what have you been up to this weekend? How's the training going?
Well, I had my parents visiting for the whole weekend. That was great. But now that they're gone, it's time to get back on the training saddle. I've had like no activity for the last 5 days. So this upcoming Saturday is the dog 5K where Bruiser and I get to run together. But we may not do it. He hurt one of his nails, and so I'm making him take the week off of running, and we'll just see on Saturday whether we can do it or not. It'll be a game time decision. But regardless, starting next week, I'm back on a new training plan. So for years, I focused mainly on lifting 4 days a week. And then it wasn't until last summer that I got back into running after a decade hiatus. But now I'm feeling motivated for running. So I want to see what kind of newbie gains I can get as I increase my running volume, but also have more intelligent running plans. So the plan is going to be to run 3 to 4 days a week, definitely 4 over time, and then bring my strength down to just 3 days a week, probably no more than an hour for each lift. I'm going to have the running program by my good friend Noah, who's a professional endurance coach, and then I'll take care of the lifting programming, more powerlifting focused. Yeah. But I will have some arm hypertrophy work in there each of the days because we all know we need bigger arms. And actually,
there you go. Yeah.
I looked up how much arm swing matters for running speed to see if I can justify increasing my arm size for running purposes and not just vanity. There's only a 2% difference in running speed between running with an arm swing versus without. So looks like it's just for vanity and not for running speed.
Oh, I like it, dude. I like it. Always trying to justify something. Well, right on, man. Nice.
Yeah. What's your training looking like?
I've been getting back in the saddle. I'm getting under some heavy weight. So like this morning I was doing some heavy back squats, 4x5, and just trying to work up to like, maybe a rep or two in reserve with that weight that I'm doing. And it was good. And then I've been trying to get more unilateral work in with kettlebells. So doing like lunges or RDLs, those types of movements you can do with free weight and load it unilaterally. And so I've been doing that a lot more, which has been fun because like not only can you get some heavy weight on those, but it just takes some more of that coordination and like cognitive thought of actually, especially with like the RDL, the single leg RDL, it takes some more focus on it, you know. So it's been kind of mentally stimulating too when you're in the gym versus just like getting under some super heavy weight and trying to push it as much as you can. So, but yeah, no, so that's been good. Getting back on that lower extremity strengthening. And then I've been doing that 3 days a week, hitting lower extremity pretty hard 3 days a week. And then the other 2 to 3 days a week, I've been mixing in just like upper body. I guess you could probably call it hypertrophy training, but yeah, so I've been mixing in a little bit of arms and core, but I've been mostly focused on that lower body.
So you're in the gym 5 days a week. Is that what you said?
Yeah, yep.
And that's really good.
So, yeah.
Show off.
Yeah, it's nice when the Anytime Fitness I go to is literally a 2-minute drive down the street. So I don't have much excuses. You know, I just find that free time and it's a 2-minute drive to get to the gym.
This might be the first year in the last 3 years where I cave and get a gym membership. I've been training in my garage for the last few years, but it's not insulated, and the winters are pretty brutal. Trying to do like any barbell work, it sucks. And then I get to use machines. Like I really want to use a leg press. I want to use quad extension, hamstring curl machines. So we'll see where that goes.
There you go. Nice. I like it. All right. Well, we can get into our podcast topic for the day. So like I mentioned earlier, we're talking about the shoulder. And Christian and I both picked, again, kind of similar cases. Not exact same, but they're both going to be centered around this idea of shoulder impingement and just kind of discussing, you know, our thoughts around it and a couple of cases that we had with it. And I think I'm gonna let Christian start us off with it. So Christian, the floor is all yours.
Sure. Well, my story today is about a 45-year-old woman with classic impingement style symptoms in her left shoulder. For those that don't know, that's typically going to be pain with certain movements or positions and not typically due to lifting a certain amount of weight, which is what you would see with more of a muscle or tendon causing your pain. Now, her story is important because it allows us to talk about the idea of impingement itself and what it really means to have it. So this client is a professional bassoon player and an amateur golfer. She came to me for left shoulder pain that happened while she was playing her bassoon and when driving, especially when her left arm was doing more of the steering. No pain with golfing whatsoever. She also came with a recent ultrasound exam from one of our sports med doctors who did find that she had calcific tendinitis of her supraspinatus, which is one of those topmost rotator cuff muscles. But the space between her shoulder joints was totally fine, totally normal. Now, for those of you that aren't familiar with bassoon, right-handed bassoon players play with their left shoulder rounded forward a lot, and they can be in that position for hours per day. And then driving, of course, also tends to make your shoulders round forward. So her pain presentation was pretty clear. The longer that she played bassoon or drove, the more pain she had. She had some pain with different muscle tests that I did, but that didn't really seem to recreate the pain that she was seeing me for. It was more about those sustained positions and postures. And because of all that, if I had to put a label on her pain presentation, I'd call it impingement syndrome. And this brings us to the conversation about what impingement syndrome really is. Like most things in PT, it's still hotly debated, but the general consensus is that impingement syndrome is a misnomer. Now we use terms like subacromial pain syndrome for pain on the top of the shoulder and coracoacromial pain syndrome for pain in the front of the shoulder. And we really only use those terms if we can't find a likely specific reason for your pain, such as a rotator cuff tear or a labral tear. We used to think that impingement syndrome meant that stuff in the shoulder was getting squished between bones that are too close together for some reason. One of those reasons that we thought was causing the squishing was that people just had weirdly shaped bones. Another reason was that people's muscles weren't doing a good enough job of keeping the bones apart. Another reason was that people's bones can have enlargements, which are often called bone spurs, that will take up more space in the shoulder joints. These reasons for shoulder impingement type pain don't seem to be as accurate as we once thought. And researchers have actually measured the space between the bones in people that have classic impingement style pain and people that don't have any pain at all. And those spaces are no different. I will say that some people do seem to have pain because of unique bone structures causing some compression. But most folks who have impingement type pain don't fall into that category. We don't have a super clear explanation for why people get pain, but it seems to be because the tissues in the area are sore from being compressed against each other, not between the bones or the joints themselves. At some point, for some reason, your body tells you that it's tired of this compression and it's asking you to make a change. So how did we help this patient? It's been a slow process, mainly because she still has to play her bassoon daily for work, often for hours, and still has big recitals with her orchestra. So our exercises have focused on total shoulder girdle strength and endurance training with an emphasis on her upper back and her rotator cuff. We've avoided anything that seems to recreate her pain a lot, since I don't believe that's the best way to get her better quickly. If this was more of a tendon pain, I might say something different and say that it's okay to go into a bit more pain, but that's not the case right now. We've also done a bunch of hands-on work to her pecs and her upper trap area to decrease some of the tightness and soreness that she has there, mainly because she feels the tightness and soreness is bothersome throughout her day. And the hands-on work has been really helpful for her, even if it's only causing short-term improvement, which she knows. But we're leveraging all available treatments for her while placing a clear emphasis on more of those active-based treatments that we talk about. So here's what I want you all to take away from this story. Shoulder impingement is a fancy way to say stuff in your shoulder is sore from being compressed. This compression is usually not due to anything wrong with your bones. Sometimes things just get tired of being compressed and they let you know by giving you pain, which then makes you change your behavior to not compress that stuff so much. Even if you have some true changes to your bone shapes that your doctor found on X-ray or MRI, you aren't doomed to have pain forever. A gradual return to those painful positions over time, combined with some comfortable exercise to the area, tends to work wonders. You don't need to fix the bones to be pain-free.
Nice. I like it. No, I think it's a really interesting story. I like your point at the end about, discussing the imaging and whatnot. And also just like the anatomy. I think that at times we can be very, pathoanatomical focused and just get so honed in on the details of someone's anatomy and we miss the big picture of everything. One of the questions I wanted to ask you, and this is kind of goes along with shoulder impingement, I think, and it also goes along with just shoulder rehab in general, or the shoulder joint in physical therapy, is a bone that's very closely related to the shoulder joint, obviously, because that's where the glenoid fossa comes from, but the scapula, and discussing different types of scapular movement, right? So like the wing scap, or, individuals like lacking, I'm just going to throw out some different terms out there, but like lacking upward rotation and lacking posterior tilting and, all these different things with that scapula that, at least in PT school, was emphasized pretty tough for me in terms of like, these are very important things. But I know now that we're kind of getting away from that a little bit. What are your thoughts on the scapular mechanics?
That is one of those topics that, again, like most things, is super hotly debated. And you're getting at, does scapular winging really matter? You probably hear that term a lot in different social media channels. But unless you have major trauma of your long thoracic nerve, which is the nerve that innervates one of your big muscles that controls your shoulder blade, you probably don't have a major scapular winging thing that needs to be addressed and really matters. we've done a ton of research on this. We've looked at people that have a little bit different scapular mechanics to see like whether they have pain or not compared to folks who have a more quote unquote normal position of their scapula. And there really doesn't seem to be any strong evidence to say that having some
Mm,
weird movement of your shoulder blade every now and again is a major problem. And I think that this often boils down to people changing the way they move in response to pain, not the change in the
mm,
movement causing their pain. We see this all the time in low back pain. People with low back pain might walk like they have a stick up their butt. It's just, it hurts. You're not going to move your spine as much, and that's going to change the way you
right.
move. It's not that the lack of movement caused your pain. Something else caused your pain. You just changed your behavior because of that. Same thing happens in the shoulder. And I will say some scapular winging is certainly going to matter, like I said, for those nerve injuries, but by and large, not a huge problem.
Yeah. Nicely put. No, I would agree with that. Yeah, I think you spelled that out pretty well. So thanks for answering that question. No, I like it. I think that was a great patient story and a lot of really good information to walk away with from that.
Cool. Well, thanks. Now I'm looking forward to yours. So who's your person?
Earlier I mentioned, we have similar stories. We're kind of talking about the shoulder and shoulder impingement today. My individual is a 51-year-old male. He is not a bassoon player or a amateur golfer. He is a UPS driver, which, hey, no hate on that. UPS drivers, all, delivery individuals, they, help make this world go around with getting us packages that we need. So thank God for them. But he is a UPS driver, and every now and then he has to carry some, heavy boxes off the truck and bring them up to someone's house. And then the other thing too is he also really likes working out with his son. His son is, forget exactly how old. He's a teenager, I know that. And he would like to they like to go to the gym together and lift weights, and, that's kind of their father-son time. So he came to me with right shoulder pain, and this was about a year ago. The shoulder pain's been going on for a long time when he came in, and he noticed most that he had pain anytime he tried to go overhead, specifically if he was trying to move heavy weight overhead. So like a military press, or some other type of overhead lift in the gym that he would do, he found that it would just kind of pinch and give him a pretty, low to moderate pain at the top of that shoulder. And obviously over time, if he tried to push through it, it would just get worse and exacerbate. So he stopped doing a whole lot of overhead stuff at the gym, and kind of like what you mentioned before, people just move differently. Helped him he found a way to help him move differently to avoid the pain in the gym, so he could keep staying healthy and doing things that he enjoys to do. And then lastly too, if there was like a heavy package he had to take off the truck, he would get some discomfort in the shoulder just by lifting, a heavy box or something like that. And so when he came in, did a pretty classic shoulder examination on him. Really all of his muscles, when I tested his muscle strength in the shoulder, anything below shoulder height, he was really strong, no pain, with the exception of a little bit of discomfort with external rotation. So, swinging that hand out to the side. The other thing though that I noticed was that if we did go overhead and test his strength, for example, like testing like lower trap strength in prone, he was fairly weak, and it would be just painful. So likely weakness from that muscle itself, but also likely weakness coming from the pain, inhibiting him wanting to resist more. So a little bit of both there, I thought. And then lastly, he did just have classic signs for impingement, like, the painful arc sign. And we can take shoulder special tests at face value as much as we want, but, when you test those classic impingement special tests on them, super provocative for them. So, like the classic Hawkins Kennedy and all those things, those were very apparently positive. Again, I know that shoulder special tests don't have the best statistics around them, so I don't want to lean too much on that, but I think it is good information to know. So, like you alluded to earlier, Christian, you talked about subacromial pain syndrome. That's what I deemed him to have for a diagnosis, was some SAPs going on in that right shoulder because of all the reasons you can rule it in. Painful arc, pain with external rotation, and positive special tests for things like Neers and Hawkins Kennedy. He also didn't show anything suggesting like major loss of mobility or instability in the shoulder. So it was pretty clear thing that it was, all right, it's probably the subacromial pain syndrome, but there wasn't a very specific tissue presenting itself that would make me think, all right, this is maybe due to a rotator cuff tear or something like you mentioned earlier. And lastly, I would classify him as pretty low irritability. Like I mentioned, mildish pain, probably like a 3 out of 10 for him when he was doing stuff overhead. Otherwise, no real pain at rest. And I think this is important to talk about the irritability because not only do we need to know a diagnosis in terms of how we want to treat them, but we need to know how to dosage that treatment. And so for him, what do we do with low irritability? We worked in pretty strong right away with some strengthening of that shoulder joint and that upper back with the hands below shoulder height. And so things like a low row, things like internal external rotation at the appropriate weight with that elbow next to the side, some shoulder extension work starting at hands at shoulder height. And those things, pain free, he did super great with those. And we were able to push that weight pretty quick, which made him mentally feel better because he was like, hey, look at this heavy weight I'm moving. I know my shoulder's hurting, but I'm doing a lot of good things in rehab right now. So I think that also really helped him. And then what we started to do is we started to train into overhead positioning with some longer holds, some longer stretch holds into that overhead. And once those became less and less irritable, and he was able to just get overhead with the body weight of his arm. And then we started to introduce some different overhead exercises, like for example, like D2 flexion or doing like prone Ys, even prone Ts. Those were a little irritable at the beginning, but towards the end, he was able to do them pretty well. He progressed really well with these and getting more of that overhead motion back and being able to load it better. We really focused on like single arm dumbbell overhead press. That was kind of our go-to to judge how well is that shoulder doing. And he was getting up there in weight pretty well. He was doing 25 pounds with no pain relatively pretty easily. So the nice thing with him was he was very educated on the gym. So once he got to this point, I gave him a nice comprehensive home exercise program, or really just a gym program to keep doing upper body strengthening. And he was doing really well with that. Now, he would still get some pain discomfort when he would really load a barbell heavy, but overall, he was really happy with where he was. He was judging it. He said he felt like he was about 80 to 90% improved, and he felt like he could get back on his own and just keep performing his rehab independently. I thought that was a great idea, especially because we know that things like rehab, it costs money. Financially for him, it just made more sense to just be on his own and independent. And so that's what we did. Sent him on his way. And then we had a little interaction later on at a gas station, which was super interesting. I was just getting gas one day, went inside to go get a coffee, and I was walking around the gas station and I saw him. I'm like, oh, dang, what's up? Insert name here. Like, how's it going? And he was like, oh, like shoulder's doing pretty well. And this was about 6 months after. And he told me that he went back to his surgeon because he was still having some of that lingering pain and he just wanted it to go away completely. And so he went back to his surgeon and his surgeon was like, I think we should do a biceps tenodesis because on MRI, that's the tissue that's being shown to be impinged in the shoulder. So they went ahead with the surgery, the biceps tenodesis surgery. And when I saw him, he was a couple months after that and he was moving his arm pretty well. But he said overall, before the surgery and after the surgery, he felt like things were about the same, which is to me really interesting when you think about, what is something like a biceps tenodesis supposed to do? It's supposed to take out that painful tissue from that susceptibility of being compressed or impinged. And in theory, that'll take away, the pain discomfort. But in his case, that low level pain when he really loaded it has been kind of staying about the same. So anyways, overall, from when I last talked to him, he seemed to still be doing pretty dang well with everything he wanted to do. He's just, he was, kind of getting back from that surgery and was kind of enjoying with where he was at. He didn't seem to be too hung up on having a little bit of that pain or discomfort left over. So my big takeaways from this is that when we're treating someone as physical therapists, it's not just about the diagnosis, it's also about the irritability level. And so if your, let's say, shoulder is saying, hey, it's go time, I feel good, and then we should be treating you accordingly versus if you can barely lift your arm away from your side, well, maybe we shouldn't be doing heavy weights to begin with. Also, even during rehab, patients can do meaningful activities at a high level. They just need a little bit of guidance. And so for him, we just need to program a little bit differently around what he wanted to do. And then lastly, if the tissue is tolerating it, load when comfortable, or if the tissue is not tolerating it, be humble to that and respect the pain. And like we mentioned earlier, or in our last episode, it's okay to poke the bear. Just don't do too much. That's my patient story and discussing shoulder pain with this individual. And overall, things went pretty well.
Yeah, well, thank you. That's a good story for everyone to hear, because something we talked about, I think, at the end of our last podcast was we should talk about stories that show us not being super successful, right? Like showing our failures,
Yeah.
or just the difficulties of rehab in general. This is one of those folks who, like, you all had a really good plan. You worked together for a long time, got him a lot better, but it wasn't quite where he wanted to be. So he went forward with surgery. And I know it's only been 2 months, you said. He's not really noticing a whole lot of change yet. Hopefully,
Yeah.
over more time, he will notice that change. So I do have a
Yep.
question about this, though. A tenodesis is a big deal. Is
Yeah.
your patient going
Yeah.
to PT someplace else? Is he cheating on you?
He might be, honestly, I don't know, because I haven't seen him back in our clinic since our last visit, which was several months ago. And then when I saw him in the gas station, he was all seemingly doing pretty well and was happy and whatnot. He didn't mention anything about doing rehab elsewhere. So he very well might have been cheating on me, or he's just an extremely smart guy and wanted to take on the process of rehab by himself. So either way, yeah, I don't know. That's a good question that you raised there. I didn't even think about that. Now I'm going to be staying up at night thinking about my
You're gonna
patients
wait out at
cheating
that
on me.
gas station for him to pop up, or maybe you just did such a
Yeah,
good job the first time around that he knows exactly what he has to do.
there we
We'll go
go.
with that
That's what
one.
I'm going to go with that one. Yeah, help me sleep better at night.
The last thing I wanted to say about your story is I really liked how you brought in those irritability levels and how we use them to guide our decision-making process. All physical therapists know that the irritability level scale is an imperfect system, but it's great when thinking about how to get someone started and like how conservative or aggressive you can be. For example, if I have someone who's wicked sore at night and throughout the day to very simple stuff like light reaching tasks, for example, I'm probably going to err on the side of caution and choose exercises below the painful threshold. And like you said, if someone is ready to go, their pain doesn't really get much worse as you do more work, you're probably better off just rolling with it and see how much they can take.
Yep. I agree, man. Yeah, 100%. Yeah, Christian, so do you have any last minute thoughts?
A little bit. So I will leave you with this advice. Developing shoulder pain is really common, and it often seems to come out of nowhere. It's usually a straw that broke the camel's back kind of phenomenon, where the issue may have been brewing for a long time, but it just took a little something to tip it over the edge for it to become symptomatic. And because your pain is not usually due to substantial damage, you're often likely to be fine after some time as you ease back into things, maybe using those irritability levels that we talked about to guide you, and doing some extra exercises for the area. And this is true even if you have real changes to your bone structure that your doctor may have seen on imaging. As we always say, your body is exceptionally resilient, and it can learn to deal with all sorts of changes in a pain-free way. So you're not doomed to be in pain forever.
There we go. Should put that on a t-shirt. I like it.
That'll be our first release.
Your body is exceptionally resilient. God, that's a good line. Man, all right, well, thanks a lot, Christian, for this for the patient stories today. I think that we both laid out some pretty nice stories and got some different perspectives on shoulder pain and difficulty at what it can be at times and when it comes to rehabbing things, especially when they're a little chronic. But anyways, well, thanks so much again, Christian, and thanks everyone for listening. We'll be on next week with a new topic and discussing some more fun things as it relates to physical therapy.